Good morning to everyone. My name is Cesare Hassan from Italy, and I'm here to present the abstract of a recent publication on clinical gastroenterology and hepatology, co-authored by Professor Perry Picard from the University of Wisconsin and by Professor Douglas Rex from the Indiana University Medical Center. The title is Resect and Discard Strategy would improve cost effectiveness of colorectal cancer screening. As you know, colorectal cancer is a major cause of morbidity and mortality worldwide. Colonoscopy has been shown to be highly effective in detecting advanced neoplasia, and colorectal cancer prevention by endoscopic polypectomy has been shown to reduce incidence and disease-specific mortality. A substantial portion of the cost of a colonoscopic colorectal cancer screening program is represented by endoscopic polypectomy, especially given the high prevalence of sub-centimeter polyps. Polypectomy costs are partially related to the cost of pathologic examination. When considering diminutive polyp, which represent over 60% of all polyps detected by colonoscopy at high-risk screening, the main usefulness of pathology examination is to differentiate between benign adenomatous and hyperplastic polyps. Recently, improvements in colonoscopy techniques have opened the door for in vivo histologic determination of colorectal polyps. In particular, narrowband imaging NBI without magnification has been shown to allow for characterization of polyp histology with high levels of accuracy. This advance could avoid the necessity for post-polypectomy histologic examination, with future management decisions being only driven by the in vivo endoscopic assessment, the so-called Resect and discard policy. The primary aim of our cost-effective simulation was to calculate the potential savings of a reset and discard policy only for diminutive colorectal lesions in a simulated colorectal cancer screening cohort and to project these results onto the US population. A Markov model was constructed for this purpose, and a simulation was performed on a hypothetical cohort of 100,000 male and female American citizens ranging from 50 to 100 years of age. Specificity and accuracy of NBI without optical magnification in differentiating between diminutive adenomatous and hyperplastic polyps was averaged by three recently published series in the medical literature. In particular, the input assumption for the sensitivity and specificity of NBI corresponded to values of 94% and 89% respectively. In order to project the outcome of our simulation on the US population, we assume a steady state for population size and age distribution represented by the year 2009 US Census data. Adherence to colorectal cancer screening was estimated to be 23%, since it has been reported that nearly 50% of the US population underwent a colonoscopy within a 10-year period, and that 46% of colonoscopy in the US are actually performed for screening indication. According to our result, in the simulated cohort of 100,000 subjects undertaking a 10-year optical colonoscopy strategy, 65,263 total polypectomies were performed, corresponding to a discounted cost of $179 per person, including pathologic examination of the resected polyp. When separating the cost of polypectomy from that of pathology, the discounted cost due to pathologic examination was equal to $46 per person. Based on this assumption, the discounted benefit due to a reset and discard strategy was equal to $25 per person. When projecting the result upon the US population, The undiscounted annual benefit of colonoscopy screening with the Resect and Discard strategy, compared with the standard colonoscopy screening approach, was estimated to be $33 million. In the sensitivity analysis, the rate of high confidence diagnosis and the accuracy for endoscopic polyp determination were the most meaningful variables. In conclusion, according to our model, a Resect and Discard policy for diminutive polyps with NBI technology would result in an annual undiscounted benefit of $33 million at baseline assumption. This would correspond to an overall saving of $330 million, assuming 10 years as the cumulative period required to screen 23% of the US population, as suggested by current estimate. The net economic benefit is largely due to saving related to fewer pathological examinations for diminutive lesions. Thanks for attention.